Welcome everyone, my name is Peter Smitham and I am an orthopaedic consultant at the Royal Adelaide Hospital. And today I will guide you through a standard hip history and examination appropriate for elective or trauma patients. You may wish to pause, skip forward and/or go back as necessary. To start your orthopaedic assessment, identify the patient, perform hand hygiene, explain the history and examination process, gain consent, and ensure appropriate exposure and positioning, as dictated by the WIPER acronym. Attention to the patient should start as soon as they enter the room. Pay attention to their gait, their face for any signs of pain or apprehension, walking aids, and always compare to the contralateral limb. Take a targeted history. Importantly, ascertain the mechanism of injury or the symptoms in the patient's own words. In a trauma scenario, the mechanism of injury may allow you to identify the most likely pathology. Pain history. We suggest using the SOCRATES acronym. Site. Where is the pain, or the maximum site of the pain? Pain arising in the hip joint is usually felt in the groin, down the front of the thigh, and sometimes in the knee. Sometimes knee pain may be the only symptom. Pain in the lateral thigh is likely due to trochanteric bursitis. Pain at the back of the hip is seldom from the joint. This is usually originated in the lumbar spine. Onset. When did the pain start, and was it sudden or gradual? Clues also whether it is progressive or regressive. The character of the pain. What is the pain like? Is it an ache, stabbing or burning? Radiation. Does the pain radiate anywhere? Associations. Any other signs or symptoms associated with the pain? Time course. Does the pain follow any pattern? Exacerbating or relieving factors. Does anything change the pain? And severity. How bad is the pain? Then move to a functional history. Inquire about any limp, walking distance, inability to run or negotiate stairs, and impacts on activities of daily living. How has this changed over time also? Remember to consider stiffness, whether there's morning or night stiffness, whether this is bilateral in location, and screening questions for other joint involvement. In young patients, specifically inquire about the following. Snapping or clicking hips. This can indicate gluteus medius tendon or the ITB slipping over the greater trochanter. Detachment of the acetabular labrum. Furthermore, screening questions for any red flags are particularly important. These would include weight loss, neurovascular changes, night pain, fever, night sweats, swelling in young patients in particular, and erythema. Previous investigations or interventions. Remember also to ask what they have tried before. You may lose some rapport with the patient if your management plan includes the treatment they feel they have previously tried and failed. If surgery is going to be considered, it is important to take a full medical history to highlight any risks of surgery and any areas which may be optimized prior to surgical intervention. Additionally, a social history is important as part of rehabilitation and discharge planning options. For example, a patient with stairs at home to get to the bathroom may need alternative arrangements, and if not recognized preoperatively, may delay their discharge planning. The MSK examination traditionally follows the simple look, feel, move. We will start with look. Ensure adequate exposure of the acquired joint, in this case groin to toes. However, shorts are worn here to maintain the actor's modesty. Ask if there is any pain before commencing, and if so, ask them to point with one finger. Please remember that you will lose rapport with the patient and your examiner if you cause pain. Therefore, please modify your examination depending on the location of the patient's pain, and examine this area last, always looking at the patient's face, so that you can recognize apprehension and pain early and stop. This is particularly important in trauma patients, but can be equally apparent with chronic conditions. Some special tests will, for efficiency's sake, be performed earlier than the special tests section. Remember that not all tests are needed on every patient, and you should consider different tests depending on what you have found in the history. Assess the trunk, pelvis, hip, and lower limbs from the front, the sides, and back, asking the patient to turn sequentially rather than you moving around the patient. Globally, from all views, assess posture, skin changes such as swelling and scars, shape, symmetry, and limb attitude, and compare to the contralateral side. From the front, comment on muscle bulk and coronal plane deformity, such as thoracolumbar scoliosis with lateral curve or limb length discrepancy. Limb length discrepancy will present with a difference in the heights of the anterior superior iliac spines. To confirm whether their scoliosis is physiological, you should ask the patient to sit down to determine if the scoliosis corrects and the shoulder heights are parallel to the floor. Blocks can also be used with the patient standing to measure the functional limb length difference. From the sides, comment on muscle bulk and sagittal plane deformity. Remember to look for scars that may be hidden under the underpants or shorts. From the back, comment on gluteal wasting and folds, and again the level of the pelvis. It is useful at this point to perform the Trendelenburg test. It is strategic to perform this before the gait assessment, as it allows you to determine if the patient will have a Trendelenburg gait present. For safety, this test is often performed with you standing in front of the patient and with you supporting them by holding their hands. Ask the patient to stand on one leg, lifting one foot off the ground by bending their knee behind them. You can then feel the pressure on the hand if they have a positive Trendelenburg sign and see the pelvis tilt. In the second phase of this assessment, we simulate the patient performing the test incorrectly by raising his knee forward and therefore hitching his pelvis up instead of the leg going behind him. Traditionally, the examiner stands behind the patient, while the patient stands on one leg. In normal hips, one-legged stance will show the contralateral hemipelvis rising. In a positive or abnormal test, the opposite occurs, with the contralateral hemipelvis dropping. Causes of a positive test include pain on weight bearing, weak hip abductors, shortened femoral neck, a chronically dislocated or subluxated hip. Now to gait assessment. The gait assessment includes rate and rhythm, as well as each phase of the gait cycle: heel strike, stance, push off, and swing phase, as depicted here. Please see our knee examination video for a full run-through. Comment on any gait abnormalities in the coronal or sagittal deformity or leg length discrepancies. Common gait abnormalities can be recalled by the mnemonic STRAWS. S for short leg, where you step down on the short leg, then vault up on the long leg to compensate, and the patient's head bobs up and down. T for Trendelenburg, abnormal pelvic tilt, resulting in the patient's head swaying from side to side. R for a rigid gait, characterized by hip hiking and circumduction of the leg. A for antalgic, with painful shortened stance phase, Imagine walking with a stone in your shoe. W for weak. Location or joint involvement dictates the weak gait patterns. For example, a weak hip gait, such as in a Trendelenburg, will result in the swaying and bobbing. Polio patient often presents with backlocking of the knee due to weakness of quadriceps. Foot drop due to common peroneal nerve palsies results in a high stepping gait, so they can clear the ground. An S supratentorial, including spastic, ataxic, or equinus gaits. Finally, don't forget to look around the room for walking aids and orthoses. Limb attitude. Lower limb trauma patients are usually unable to walk, and it's important to assess the limb attitude while supine, as it will give an indication of common pathologies, including neck of femur fractures and hip dislocations. An externally rotated limb with lateral foot touching the bed would suggest an extracapsular neck of femur fracture. An externally rotated limb with lateral foot not touching the bed would suggest an intracapsular neck of femur fracture or malpositioned arthroplasty. A flexed, adducted and internally rotated limb would suggest a posterior hip dislocation. A flexed, abducted and externally rotated limb would suggest an anterior hip dislocation. But also in a young patient or those with suspected hip infection could indicate synovitis or hip joint effusion, as it is the position of least capsule tension. While supine, take this opportunity to assess leg length, quantify any discrepancies and identify where this is located. For true measurement, square the pelvis with the anterior superior iliac spine at the same level and measure from the anterior superior iliac spine to the medial malleoli on both sides. Also assess apparent leg length discrepancies by measuring from the xiphisternum or umbilicus to the medial malleoli. If true shortening is present, you need to identify if the discrepancy is located in the tibia, the femur, or both. This is performed by using Galeazzi's test, by flexing the hips to 45 degrees and the knees to 90 degrees, with the feet flat on the bed, looking for asymmetry in the heights of the knees from the side and above. Please note, if shortening is in the femur, it can also be above or below the greater trochanter. Assess this by palpating the anterior superior iliac spine with your thumb, the greater trochanter with the middle finger, locating Bryant's triangle, and compare to the contralateral side. Now assess for tibial shortening. Finally, don't forget to assess functional limb length standing. Now on to feel. Whilst supine, palpate sequentially with one finger for any sites of tenderness and or swelling. Palpate the anterior superior iliac spine, then the greater trochanter. If unable to feel this, roll the leg internally and externally to assist in localizing it. Move your fingers posteriorly from the greater trochanter to palpate over the piriformis tendon. This will elicit pain in piriformis syndrome. Now to move. Remember to note the approximate angles achieved for all movements. Active movement should always be done before passive. This is a good opportunity to perform Thomas's test for fixed flexion deformity of the hip. It can be performed with the patient undertaking active movements and allow the patient to flex the hip and assess flexion and extension at the same time. With the patient supine, ask them to pull both knees to their chest and hold them with both hands. The examiner places a hand under the lumbar spine to ensure the lordosis is obliterated. Then ask the patient to release one leg and lower it flat towards the table, whilst stabilizing the other knee in maximum hip flexion. A positive test is when the patient cannot get the limb flat to the table, which represents the amount of fixed flexion deformity the patient has. Maintain your hand under the lumbar spine to ensure that they do not lift or tilt the pelvis in extension of the leg. Flex the hip and knee to 90 degrees. Note if there is any obligate external rotation, which potentially indicates a slipped proximal femoral epiphysis or retroverted femoral neck. Obligate internal rotation may suggest a torn acetabular labrum in younger patients. Assess internal rotation and external rotation with the hip flexed to 90 degrees and in full extension. To assess hip abduction, level the pelvis by ensuring anterior superior iliac spines are in the same horizontal plane. Furthermore, stabilize the pelvis with one hand on the contralateral iliac crest, thus preventing pelvic tilt, and bring the limb into full abduction, with 0 to 40 degrees being normal. Proceed to adduction with same stabilizing forces to iliac wing, and watching pelvis to identify movement of tilt. If you are unsure about if the pelvis is tilting in abduction and adduction, you can lock the pelvis by lowering the contralateral leg over the side of the bed in full abduction. Special tests. Whilst in the supine position, we can assess the following special tests. For deer, flexion at 90 degrees, adduction and internal rotation, with hip or groin pain suggesting labral tear or anterior femoral acetabular impingement. FABER, aka Patrick's test, is flexion, abduction, external rotation, asking if the pain is at the front or the back. Anterior groin pain may indicate hip arthritis or iliopsoas pathology, whilst posterior pain may indicate sacroiliac pathology. Now, in the lateral position, assess resisted abduction by asking the patient to elevate their lower limb while observing for signs of pain. This may indicate trochanteric bursitis. Next, perform the psoas sign. Passively extend the hip. Any pain elicited anteriorly may indicate psoas bursitis or an abscess. Although not usually part of the hip exam, in a patient with history of radicular back pain, you may wish to perform a straight leg raise test to assess for sciatica. This is a passive neurodynamic test with the knee extended and the hip flexed to the point a patient complains of discomfort or neuropathic pain posteriorly in the buttock, radiating down the thigh and the leg. Note the degree of hip flexion at which the patient experiences pain. To further assess this, bowstringing the sciatic nerve by applying pressure in the popliteal fossa may also cause pain. Additionally, by lowering the legs slightly and performing passive dorsiflexion of the ankle may also reproduce the pain down to the foot again. Finally, complete your examination with a targeted neurovascular examination, depending on the patient's presenting pathology and the planned treatment options. For the hip, a minimum assessment would be lateral femoral cutaneous nerve of the thigh over the anterior lateral proximal thigh, the superficial peroneal nerve over the lateral malleoli, the saphenous nerve over the medial malleolus, the medial plantar nerve feeling the plantar aspect of the great toe, the deep peroneal nerve over the first dorsal web space of the foot, and finally a vascular assessment starting distally and assessing proximally if indicated. Dorsalis pedis pulse, posterior tibial pulse, and the popliteal pulse with the passive flexion of the knee to 10 to 20 degrees. Thank you all for your attention. Please remember, when it comes to orthopaedic examinations, look, feel, move, and special tests is imperative.